Welcome to the GP webinar for Berkshire. Hi, my name is Rosray and I'm the Clinical Education Lead for BEAT. I'm a mental health nurse by background and have worked within the field of eating disorders for over the past 23 years, both with adults, young people and their families. Berkshire have commissioned this bespoke webinar for GPs working within this area to support you in the outstanding work you're currently doing and to offer some support and education specific to eating disorders. As you know, eating disorders are a serious mental illness. They are complex and multifactorial, and this training will highlight this. Eating disorders are treatable conditions and recovery is possible. Recovery is, however, rarely smooth. If it is, it's often a concern, because the bumps along the way help to understand triggers and how to manage with alternative coping mechanisms to their eating disorder behaviours. What is important is early identification and intervention, which we will cover more in due course. This training has been developed using feedback from GPs and service users. It will include videos from professionals working within the field of eating disorders alongside those with lived experiences. This training will aim to equip you with the knowledge and skills needed to be able to identify and assess eating disorders, provide medical assessment and treatment, referrals and referral pathways to specialist services, and to understand the psychological impact of eating disorders. Resources and an assessment checklist will also be available. So the learning objectives are early identification, so looking at the early warnings as a sign, risk factors, clinical features, the impact and prevalence of eating disorders. An increased understanding of the common challenges experienced by clinicians identifying people with eating disorders. Understanding from the sufferers of eating disorders about how they confronted their illness and GP support. And understanding how to access services for an eating disorder and manage risk, including engaging families and support. And recognising the official guidance and care pathways available, and for you all to feel very confident to access these. So the importance of early intervention is reflected in the NICE Guidelines 2018. People with an eating disorder have better recovery rates and a reduced risk of relapse when they receive early intervention in eating disorders. Early intervention may also reduce the need for hospitalisation, which would be cost saving. Delays in starting assessment and treatment can affect response to treatment, with a longer delay having a greater effect on outcomes. Early intervention is vital. The longer the illness persists, the more the eating disorder will be in control, making treating it more difficult. Recovery is possible. The majority of those diagnosed with an eating disorder will and do make a full recovery, so it's important that this is spotted early. Paradoxically, the challenge of early intervention is that those presenting with an eating disorder are often at their most resistant to acknowledge they have an eating disorder and therefore making any change. The eating disorder is probably working for them, thus having the desired effect of numbing emotions, reducing anxiety, giving them more confidence. It's a friend or protector, and it can combat loneliness and emptiness. It can provide consistency, structure and routine, and gives them a sense of being different or special. One sufferer stated, "It almost cost me my life, but at the time it felt like my best friend. I had found something I was good at when I felt I was worthless at everything else." As a GP, you may play a crucial role in early identification, medical management, diagnosis and referral to specialist services. You can and may help prevent the development of an eating disorder. GPs are often the first point of contact for those with an eating disorder, and responding to this using your clinical skills increases the person's chances of recovery. You are the face of the healthcare system for most patients, and the pressure is immense. As a GP, you demonstrate and need a much broader knowledge and skills base than most professionals will ever need to achieve. And this webinar aims to increase your existing knowledge and understanding of eating disorders and how you can support those with an eating disorder and their families. Within Beat's paper, Delaying for Years, Denied for Months, we asked people with a lived experience with eating disorders how long they had an eating disorder before they were able to realise this. The longest delay to treatment is the period before recognising the signs and symptoms of an eating disorder. People wait on average 3.5 years between falling ill, seeking help, and starting treatment. Between realising they have an eating disorder and seeking help can take on average over a year, and adults wait twice as long as under 19s. Once they finally sought help from a GP, it can take another 6 months before they can begin treatment. Only 14% of people are referred within 4 weeks of their first GP visit to a specialist service, and men and boys wait 28 weeks for a referral compared to 10 weeks for women and girls. 25% of sufferers aged 19 and over were referred to non-specialist services. These delays to treatment result in an average cycle of relapse and recovery lasting for 6 years, with major health, emotional and financial impacts on those with eating disorders, their families and the NHS. On average, carers spent £32,672 as a result of their loved one's eating disorder. Help seeking can be incredibly frightening for someone with an eating disorder, and many people we talk to describe feeling too afraid to seek help. Before people with an eating disorder come to speak to a GP, many feel ashamed, embarrassed, or afraid of being judged. Some people with eating disorders may worry that they're not sick enough to seek help, that their symptoms are not severe enough to be diagnosed as an eating disorder, or that GPs will not take their symptoms seriously. Some doubt their own symptoms, worry they won't be believed, or they'll be accused of attention seeking. Other people tell us that they worry about GP confidentiality or fear that the GP will inform their family. An awareness of eating disorders can often be lacking in the community. So what can we take from this? Early signs of eating disorders, including sub-threshold symptoms, need to be taken seriously for effective early intervention for eating disorders. Many people with eating disorders tell us they have an understanding and patient GP who took time to listen to their experience, and this was incredibly important. Reassuring people with eating disorders that their symptoms are valid can be an incredibly important part of that consultation and can make a real difference. It's important to remember that eating disorders can present at any weight, and sensitivity around weight is particularly important when working with somebody with an eating disorder. Many people tell us they would have been encouraged to seek help sooner if they'd felt you don't have to be a certain weight to receive treatment, or that there was less stigma around weight. So eating disorders are serious mental illnesses that affect over 1.25 million people in the UK, and they're characterised by an unhealthy relationship with food, a preoccupation with body image, weight and shape. They can affect anyone regardless of age, gender or background, and can be dangerous if left untreated. And anorexia has the highest mortality rate of all psychiatric illnesses. Statistics taken from the National Institute for Health and Care Excellence in 2017 and 2019 showed that anorexia was overall the rarest eating disorder, approximately 15% of cases, although this was more common in younger people. There was a higher incidence in people aged between 15 to 19 years old. The Royal College of Psychiatrists estimate that over 700,000 people in the UK have an eating disorder, 90% of whom are female. And this is likely to be an underestimate, as many cases don't present to health services. As we said, anorexia has the highest mortality rate than any other mental health disorder. The mortality rate for anorexia is around 5.1 deaths per 1,000 people per year. So 20% of these deaths in people with anorexia are due to suicide. Weight is an unreliable measure alone to diagnose anorexia nervosa, and we need to look beyond this. NICE guidelines are trying to get away from this and focus on how people present as a whole. Someone with anorexia has a marked fear of fatness, a strong belief they are fat even when they're underweight, and an intense fear of any weight gain. Everything they do, every decision they make is about their weight and how to reduce this. They have a severe preoccupation of weight, shape, and food. There's an overvalued ideation of weight and shape, and an intense desire and drive for thinness. And this is central to their self-worth, their confidence and self-esteem. Their mood is often directly reflects their weight loss or gain. They may present as angry or low in mood if they haven't lost weight, or happy if they have managed to lose some. Most cases of anorexia nervosa are noticed by parents, friends, and teachers rather than by the person themselves. Often what accompanies this illness is an intense denial that they have a problem. So there are two subtypes to anorexia nervosa. There's restricting, where weight loss is accomplished primarily through dieting and excessive exercising, and severely restricting calorie intake may be less than 500 calories a day, and excessive exercise is often used as a punishing routine. And then there's a binge purge type, where people are still of low weight, but they regularly engage in binge eating or purging, or both during this current episode. Some do not binge, but regularly purge after small quantities of food.
You're tired a lot of the time. Obviously, you're hungry a lot of the time, which then makes you quite irritable. So I probably wasn't pleasant company. And I think to an extent I knew that. But also I had hugely low self-esteem and hated myself. So knowing that I wasn't good company or that I was being snappy with people and things actually just made that worse and spiraled. I really didn't like myself. And that wasn't just how I looked. For me, I don't think I ever had dysmorphia. I don't think it was ever a case of thinking I was fat when I wasn't. I never thought I was fat. But I hated how I looked. I thought I looked disgusting, but I hated who I was. I thought I was an awful person, and I genuinely couldn't understand why people were friends with me and why people liked me. I thought I was a freak. I thought I was ugly, a horrible person, selfish, dramatic. Pretty much any word you can think of that people use to describe people they don't like, I was applying to myself. And that is, yeah, really tough. I think for me, it wasn't really about the food. Certainly initially, I think it was a way of control, and I did get a high from it. There is a rush of feeling when someone tells you to do something and you say no, that potentially everyone experiences, that slight rebellion. And I got that every time someone tried to make me eat and I refused, or I found a way out. I'd find myself thinking, yes, I've gamed the system, I've won. And it did feel like a victory. Again, every time someone said that I looked skinny or that I looked unwell or that they were worried about me, my brain saw that as a win and that I'd done something right.
Bulimia nervosa. The peak age of onset is in later adolescence and young adulthood, of kind of age 15 to 25 years, and is less seen in children. Men with an eating disorder, there's a higher percentage that have bulimia nervosa than anorexia nervosa. People with bulimia nervosa are usually not underweight, but often within the healthy body weight range, which may contribute to why it often remains undetected for approximately 6 years. And it may be at this point that they ask for help. So their weight may fluctuate. Bulimia nervosa is characterized by recurrent episodes of binge eating, a profound loss of control of eating. They may have numerous binges a day, a few times a week to every day for months. It's cyclical, so people typically go through a repetitive cycle of restriction, binging, and purging. Restriction is adopted as a means to lose weight. However, this leads to feelings of hunger and emptiness, both physically and emotionally. Binging can bring a release from the tension and following a trigger, including breaking self-imposed dietary rules and plans. Binging then triggers feelings of guilt, shame, and disgust. They then purge as a compensatory behaviour, as they have a severe preoccupation with shape and weight. The overvalued ideas around this are central to their self-worth, self-esteem and confidence. And purging can take a variety of different forms. So there can be self-induced vomiting, and this may be after a binge or after food or drink. It could be misuse of diuretics or laxatives or excessive exercise.
Isolating. It was an incredibly lonely experience. When my bulimia was at its worst, I was at university. So even though I was surrounded by friends, at the end of the day, after lectures, after having dinner, I could just go to my room, and that would be when the binges and purges occurred, and no one knew, and it took me a very long time to be able to confide in someone and tell them what was happening. And one of the things I really struggled with as well was that my eating disorder brain decided to convince me that I wasn't ill. I would, during binges and purges, I would have these thoughts like, you're not eating enough, you're not binging enough food, you're not purging enough, you need to do more. And then that I would convince myself that I wasn't ill and that I didn't need help. And that was something that stopped me from getting treatment earlier. And so yeah, I didn't know at the time that is quite a common thought process to have people with eating disorders. So yeah, but and even when I had the diagnosis, even when I was getting treatment, I still had those thoughts. So yeah, that was really difficult. And also I found the physical side effects that wasn't very nice. I would get quite bad stomach pains. I would have a very croaky voice. So yeah, it wasn't just the mental side of things, it was the physical side effects as well, which I really struggled with.
Binge eating disorder is defined and now recognised as an eating disorder in its own right since 2014. The last official figures, which were before this formal recognition, was 10% of eating disorder cases are in this category, but it's estimated to be nearer 30%. Bingings occur on a regular basis, and the key difference to bulimia nervosa is that they do not use any purging behaviours afterwards or make any compensatory attempts to prevent the consequential weight gain. They sit with the emotional, often and punishment, and this may trigger a binge as they use the binge to emotionally regulate. Often these are very emotionally charged as they're in touch with the emotions when not binging. They don't purge or exercise them out, so unless binging, they're not numbing those feelings and emotions. Beat Helpline advisors described how people with binge eating disorder are full of emotions when they speak to them, and they are most in touch with their raw feelings. Bingers are often secretive, not wanting others to see how out of control and the large quantity of food that's consumed, maybe days' worth of food within one sitting. During a binge, they eat much more rapidly and with a loss of control. They often eat until they feel uncomfortably full and eat large quantities when not physically hungry because they are emotionally hungry. Often people with binge eating disorder become socially withdrawn as they are unhappy with their weight and appearance. Many will make an effort to control their diet outside of the binges, so a pupil who may appear to be eating healthily but whose weight is increasing may be secretly binging. Weight gain will continue until the underlying reasons for the binging are addressed, and weight gain will usually be far in excess of that expected for a child for their age. Binge eating is not about greed, it's an eating disorder and needs to be treated as such. Males have a 43% higher chance of being diagnosed with binge eating disorders compared with male cases of anorexia and bulimia nervosa. So on a regular basis, the person with binge eating disorder experiences a lack of control, eating large quantities of food over a short period of time in an attempt to manage difficult emotions and thoughts. ARFID, Avoidant Restrictive Food Intake Disorder. The DSM-5 defines this as an eating disorder or eating or feeding disturbance, e.g. apparent lack of interest in eating or food, avoidance based on the sensory characteristics of food, concern about aversive consequences of eating, as manifested by persistent failure to meet appropriate nutritional and/or energy needs. ARFID involves limiting the amount of types of food, but unlike anorexia nervosa, there's no distress about body shape or size or fears of fatness. For a diagnosis of ARFID, you would need to present with eating or feeding disturbances with one or more of the following: significant weight loss or failure to achieve expected weight gain or faltering growth in children, significant nutritional deficiency, or dependence on enteral feeding or oral nutritional supplements. And within ARFID, there is a marked interference with psychosocial functioning. Some of the warning signs to be aware of with ARFID: the behavioural and psychological, there's dramatic weight loss. Somebody might dress in layers of clothes to hide their weight loss or stay warm. They may come to you reporting constipation, abdominal pain, cold intolerance, lethargy, and/or excess energy. They may report consistent vague gastrointestinal issues, upset tummy, feeling full around meal times that has no known cause. There could be a dramatic restriction in the type or amount of food eaten, or they'll only eat certain textures of food. There could be fear of choking or vomiting, a lack of appetite or interest in food, a limited range of preferred foods that becomes narrow over time, e.g. picky eating that kind of progressively worsens. But again, of significance, there's no body image disturbance or fear of weight gain. Because both anorexia and ARFID involve an inability to meet nutritional needs, both disorders have similar physical signs and medical consequences and risks. So in ARFID, the body is denied the essential nutrients it needs to function normally. Thus, the body is forced to slow down all of its processes to conserve energy, resulting in serious medical consequences. The body is generally resilient at coping with the stress of an eating disorder and behaviours, and laboratory tests can generally appear perfect, even if someone is at high risk of death. Electrolyte imbalances can kill without warning, soaking cardiac arrest. Therefore, it's incredibly important to understand the many ways that eating disorders affect the body. So, OSFED, other specified food eating disorder, used to be called EDNOS. A person must present with feeding or eating behaviours that cause clinically significant distress and impairment, but don't meet the full criteria for any of the other disorders. Orthorexia is not formally recognised as a diagnosis in the DSM-5. However, it has similarities with anorexia nervosa. This condition focuses on pure or healthy foods, and what this means will differ from one person to another. The DSM-5 criteria for rumination disorder is repeated regurgitation of food for a period of at least 1 month. And regurgitated food may be re-chewed, re-swallowed or spat out. And the repeated regurgitation is not due to a medical condition, e.g. a gastrointestinal condition. The behaviour doesn't occur exclusively in the course of anorexia nervosa, bulimia nervosa, binge eating disorder or avoidant restrictive food intake disorder. If it occurs in the presence of another mental disorder, for example, intellectual development disorder, it's severe enough to warrant independent clinical attention. PICA, there are no laboratory tests for PICA. Instead, the diagnosis is made from a clinical history of the patient. So diagnosis for PICA should be accompanied by tests for anemia, potential intestinal blockages, and toxic side effects of substances consumed, for example, lead paint, bacteria, or food disorder. So PICA is an eating disorder that involves eating items that are not typically thought of as food and that don't contain significant nutritional value, such as hair, dirt, paint chips, charcoal, clay. As I said, iron deficiency, anemia, and malnutrition are two of the most common causes of PICA, followed by pregnancy. And in these individuals, PICA is a sign that the body is trying to correct a significant nutrition deficiency. And treating this deficiency with medication or vitamins often resolves the problems. So one of the ways to understand eating disorders are to envisage a critical inner voice. This is called externalization and adds to the complexity of the illness. It can be a powerful influence on the person with the eating disorder and how, as professionals and carers, we relate and understand the eating disorder. The aim of seeing the person and the eating disorder as separate entities is to enable us to challenge the eating disorder and come alongside and support the person to understand, challenge, and manage this critical voice. These are quotes from some people with lived experience of an eating disorder as they shared with us some of what their voices say to them. I'm going to show you an excerpt from Dr. Laura Hill's TED Talk, which illustrates the eating disorder voices extremely well. I would also urge you to try and find the time to watch all of this, as it's a good summary and reflection of what it's like to have an eating disorder and the biology, particularly in relation to the brain that underlies this.
But a person with an eating disorder, such as anorexia, when they eat, they experience high anxiety, extreme thought disturbance, and noise. I want to give you an idea of what that noise sounds like. And so the person who has an eating disorder and has had her breakfast, she's now trying to go to work. She's trying to go to class. And the noise and the disturbance is acute. She's trying to hear her professor through the noise. She's trying to hear her employer talk to her and have an interaction with her. And she's trying to focus through the noise. So how in the world, if she's going to have her breakfast and then she's supposed to have a lunch and she's supposed to have dinner too, and the noise continues to be acute, how can I function? How can I work? How can I have a decent interaction and a clear, focused interaction and get this project done? How? Simply by not eating. Because if I don't eat, Dr. Hill, I can then think more clearly. If I don't eat, Dr. Hill, please just don't have me eat breakfast. Then I can get this assignment done, and then I'll go ahead and eat something, so then I can go ahead and get something because you say you're needing it. But don't ask me to take that test and eat breakfast too. Because if I do, I have to take the test and think through the noise. I have to finish the assignment and think through the noise. So what do we do to be able to help a person with anorexia whose mental noise is so disturbed, yet they need food? So let's explore what's going on in the inside of the brain so that we can better understand what that looks like.
So truths around eating disorder. A harmful myth is that a person must be underweight to have an eating disorder. In reality, most people with eating disorders are not underweight, and eating disorders happen to people of all body shapes and sizes. A related myth is that if a person is not underweight, their eating disorder is not severe. Although being underweight is medically unsafe, people with eating disorders who are not underweight can have serious health issues that can't be seen with the naked eye, such as electrolyte imbalances, digestive problems, and/or cardiac issues. Thus, eating disorders can have lethal health consequences in people of all body size. Truth 2. Families are not to blame and can be the patients and your best allies in treatment. Truth 3. An eating disorder diagnosis is a health crisis that disrupts personal and family functioning. Truth 4. Yet another harmful myth about eating disorders is that they are a choice. No one chooses to have an eating disorder. We know that eating disorders begin from complex interactions of biology with social, cultural, and environmental influences, but no one chooses them. Truth 5. Eating disorders do not only happen to young, wealthy, heterosexual, white, non-transgender girls and women. Recent research using samples of people from around the world have busted this myth by showing that eating disorders affect individuals of all ages, genders, sexual orientations, races, ethnicities, and socioeconomic statuses. Truth 6. Eating disorders carry an increased risk for both suicide and medical complications. Truth 7. Genes and environment play important roles in the development of eating disorders. Susceptibility genes to eating disorders are associated with loci linked to affective disorders, such as serotonin receptors, opioid receptors, and BDNF, brain-derived neurotrophic factors. Puberty is a significant risk factor for an ED. It's also suggested that some genes can be activated by the developmental changes in the brain. So during puberty, neuronal links are pruned and the frontal lobes responsible for self-regulation are developing. Truth 8. Genes alone do not predict who will develop eating disorders. Genetic factors can contribute to the risk of developing an eating disorder, and having a relative with an eating disorder increases the risk in the family by tenfold. However, genes alone don't remain static over an individual's lifetime. External events can switch on the expression of genes, explaining a lifetime duration of gene-environment interactions. Truth 9. Full recovery from an eating disorder is possible. Early detection and intervention are important. Common consequences of eating disorders can be social, psychological, and physical. So in terms of the social consequences, some of the things that you might be asking for in your consultation is, has that young person started cancelling friends, not going out with them to avoid eating food? Do they compare body weight? Are they on websites that may be unhelpful to them, where they are doing a lot of body comparison? The psychological consequences are this over-evaluation of weight and shame, and how that links into self-esteem, fear of becoming fat, and cardiovascular or gastrointestinal. They're all there for you to read. Common consequences of eating disorders can be social, psychological, and physical. So looking at primary care responsibilities, if you're triaging over the telephone and someone's presenting with difficulties in eating, arrange a face-to-face consultation. They may feel very hesitant and ambivalent about change and may not be at a point where they are aware that they have an eating disorder. NICE guidelines recognise that as GPs, you're in a special position to screen certain groups of patients. Others at risk include individuals with gastrointestinal disturbances, menstrual irregularities or amenorrhea, and any child with growth problems. Most of these patients will have other reasons for their symptoms, but the guidelines ask to consider excluding an eating disorder. To help you in this screening process, it's suggested that you ask a direct question. For example, do you think you have an eating problem, or do you worry excessively about your weight? If we consider the next case study, Jemima is 17 years old. An appointment has been made as she's feeling tired all the time. Jemima started dieting before the summer to lose weight before she went on holiday. Her current weight for height is 100%. She's lost 12 kilograms over the past 12 weeks. Jemima is tired all of the time and concerns that her periods have stopped. And Jemima describes having high levels of anxiety after she has eaten with her family and friends. Is Jemima presenting with an eating disorder? What information are you basing your decision on? And does Jemima need a referral to a specialist service? So is Jemima presenting with an eating disorder? Yes, possibly. And what information are you basing your decision on? Significant weight loss over a short period of time and anxiety after eating. There's potentially likely to be a fear of weight gain and distorted thoughts around eating and weight. Does Jemima need a referral to specialist services? Yes. Many people with an eating disorder may be really ambivalent about seeking help. Like I said before, they may feel that they're not ill enough or can't allow themselves or give themselves permission to stop the ED thoughts and behaviours. How you can help. So engagement is key. Validate the importance of them talking openly about their eating disorder. Focus on the emotional impact of the eating disorder thoughts and behaviours regardless of their weight. Give them permission to identify as ill enough and validate their experiences. And confirm that the patient does deserve help and is in the right place. Compassion is key. A positive outcome would be, you did the right thing coming to see me. Here's what you can do. The patient feels that the eating disorder is being taken seriously and may start to feel some permission to stabilise and commit to recovery. A negative outcome would be if you were to say your weight's not yet low enough for treatment. The patient feels invalidated and not sick enough to deserve to recover, and the eating disorder may often go away and get worse and will not go away if unaddressed. Remember, your patient may tell you what you want to hear rather than the reality of what's going on. Patients may be feeling ashamed, scared, and ambivalent about seeking help. Encourage them to talk openly and ask questions. You might want to use the SCOFF questionnaire. Have you set yourself strict rules around food? How do you feel about social events involving food? Do you feel you're less spontaneous within social situations? Do you find yourself lying to people about the amount of food that you eat? Do you find yourself thinking about food most of the day? Do you find that you are indecisive and spend excessive amounts of time in supermarkets looking at food? Do you have feelings of guilt after eating certain foods? Do you feel like you have a constant internal battle with yourself when it comes to deciding what to eat? How often do you weigh yourself and how does it make you feel? Do you find yourself trying to falsely justify your food decisions, e.g. saying you don't like something when you do? Do you find that you don't seem to laugh or have fun anymore? Eating disorders are not just about food, they affect all aspects of a patient's life. Other things to explore are their family support, any history of eating disorders in the family, occupation, relationships, and the level of exercise and activity. This is a quick guide to identifying diagnosis. Remember, your patient may tell you what you want to hear rather than what's really going on. So for the physical examination, you will be doing weight for height or BMI, blood pressure, lying and standing, examination of the skin and temperature for those at high risk of dehydration, and a full physical examination. Some GPs also do the test of muscle strength using the squat test and stand-up squat test. Patients asked to squat down on their haunches and asked to stand up without using their arms as a lever if possible. The other things you would be looking for is your testing for hydration, notice is there dizziness or fainting, standing up from sitting, whether there's a postural drop, and looking at the difference between the lying and standing blood pressure and heart rate. Frequent investigations, full blood count and chemistry, FBCs, ESRs, U's and E's, creatinine, glucose, LFTs, magnesium and phosphate are necessary. If the patients are at a high risk category from a previous assessment or your assessment that day, they have a BMI of less than 15, the BMI is less reliable due to features outlined above, or there's a history of purging. Again, an ECG is recommended if the BMI is less than 15 kilograms squared, and if drugs which have an effect on the QT interval are prescribed. And then any other appropriate physical investigations pertinent to the health that you feel relevant. So potassium, this is often chronically low in purging, even down to values of 1.5 millimoles per litre, with no immediate sequelae. Acute changes are more dangerous. Regular feeding with control of purging is usually sufficient for re-establishment of normal levels. If potassium replacement is required because it's usually caused by a lot of gastric secretion, it should be done with oral replacement with a salt and water replacement such as a diarylyte, with regular electrolyte review and examination of fluid and water status. Refractory hyperkalemia can also be due to concurrent low magnesium or calcium, and these levels may need checking and rectifying. Serum potassium levels may remain low even with potassium supplements if the vomiting persists. A proton pump inhibitor such as lansoprazole to inhibit gas acid secretion may reduce metabolic alkalosis and help to conserve potassium, but should be a second-line measure. Phosphate rebound hypophosphatemia can occur in initial refeeding as it's sequestered by carbohydrate metabolism. It can be lethal. Initial refeeding, including foods with high phosphorus content, e.g. milk-based products, may be helpful. And if necessary, about 4 days of oral phosphate supplementation may also be needed. In anorexia nervosa, it's rare for there to be an isolated deficiency of any mineral or vitamin, and therefore multivitamins and mineral placements is recommended, for example, Forceval or Nitrogen Gold. Refeeding oedema, so peripheral edema, is common and harmless during initial refeeding. It resolves within a few weeks spontaneously and rarely needs treatment. It must, however, be distinguished from edema secondary to heart failure. Dehydration, this can rapidly lead to medical crisis through circulatory and renal failure. All patients should be fully assessed for dehydration, taking a corroborative history of fluid intake and signs of decompensation such as dizziness or fainting. The physical examination should include assessment of skin turgidity, ocular pressure and lying and standing blood pressure. Regular electrolytes should be checked for high urea, creatinine, sodium and potassium levels, and oral replacement is preferable. Bradycardia investigations with an ECG, looking for a heart block or prolonged QT, and measures Usinase. If lower than 40, then admit. And obviously, if hypothermic, ensure that they're monitored overnight and kept warm. So physical monitoring whilst awaiting referral. Whilst you've done the referral to the specialist eating disorder service, arrange a regular review to both monitor physical and mental health. Assess for biochemical and ECG abnormalities. Inform the patients of the online BEAT services that they and their family can access for support and information, because the aim is to actually empower the families and your patients to begin treatment whilst they're waiting for a specialist assessment. Encourage patients to take an appropriate vitamin substance and refer to and follow all the risk management guidelines, which will be highlighted at the end of this. So the management of really sick patients with anorexia nervosa, the marzipan guidelines, arose out of concerns that a number of patients with severe anorexia were being admitted to general medical units and sometimes deteriorating and dying on these units because of psychiatric problems, such as non-adherence to nutritional treatment and medical complications such as refeeding syndrome. Treatment will almost always be within the patient or parent's consent, but GPs are reminded that the Mental Health Act or Children's Act may be required if needed. When you are assessing, use the marzipan protocols or the new management of emergency eating disorder intervention protocols that will be coming out imminently to assess risk within your general practice. Weight for height charts are used in young people as they reflect the expectation is that their weight will change as they grow and develop. So the calculation is based on their weight from the date of their birth to the day that they are weighed, and calculated on weight for height ratios for expected weight and height range for their age. It's important to include weight and percentage weight for height on your referrals, alongside a recent history of any weight loss and rapidity of this. You can also use the NHS BMI calculator, as whilst this doesn't give you weight for height, it does explain weight in percentiles relating to the age of the child. When you're weighing a patient, imagine I ask you to weigh yourself in front of a family member, and then I'm going to share your weight with various random people. You know, if you think about how that might feel to be asked to do that. Some people describe trying to think of any ways that they can get out of it. People have lied to say they don't have any scales when they do have scales. They thought about lying on the number of scales or changing their clothes. And I want you to think about how the young person you're caring for might react to being asked to being weighed, What kind of behaviours do you think they might use to manage that anxiety? So what we know is that before, during and after being weighed is an extremely anxious time. Be aware of those compensatory behaviours. Weighing is a therapeutic intervention in itself and requires understanding and sensitivity. Ensure that you create a safe environment that is private and confidential, and be aware of the need to offer support after weighing, as often the eating disorder is strong if they have restored or lost weight. Remember, just because they've identified it and spoken with the individual, making a referral doesn't mean that the individual will automatically want to get better. So if you're unsure if someone has an eating disorder, encourage them to make an increase in their dietary intake and monitor this. Engage the person and the family in a process of ongoing assessment. Await results of the physical investigations carried out. Ask the person to complete an eating disorder examination questionnaire and EDQ, which you'll find attached to the end of this webinar. Contact your local eating disorder providers and discuss your concerns. Make a follow-up appointment as soon as possible. Give information about assessing emergency treatment if needed, and give resources around eating disorders for the patient and their family. Explain what you're going to do next and why, and seek their consent to do that. So what we're saying is refer all young people and adults whom you believe to be presenting with an eating disorder. Indicators for this are a history of weight loss of more than 1 kilogram for 2 consecutive weeks, or a failure to gain weight. If no weight is available, have their clothes size changed? Have parents noticed weight loss? How long has the person been trying to lose weight, and what have they tried? Are they binging, vomiting, or using laxatives? And if so, how often each weekday? Are they over-exercising? And clarify what activity they are doing on a daily, weekly basis. How much are they currently eating and drinking? Have parents noticed if they're eating in secret? If appropriate, are they menstruating? What is their weight history? Children and young people do not need to be underweight for a referral. Low weight is now defined as a loss of 10% of a young person's expected body weight. The rapidity of weight loss is also important in gaining a clearer clinical picture. Remember, weight loss is not the only indication of a potential eating disorder. In regards to consent, are both the young person and parents aware of the referral? Often young people can be hesitant in telling their parents, as they may feel embarrassed and ashamed or want to protect them. Having an open discussion with the young person around this and explaining the need for their parents to know is important. Also, we know that those struggling with an eating disorder can sometimes lack insight into the fact that they have a problem. So what to include in your physical examination? So weight and height. Again, we've spoken about how weighing someone with an eating disorder can be challenging, as they may resist this due to a fear of being judged by you, or a fear that they will be told they're not ill enough, and a fear that the eating disorder will make them feel ashamed and embarrassed about their weight. As a consequence of this, eating disorders can sometimes convince the young person to influence their weight in different ways. This may be adding weights to their pockets, hiding things in their clothes, hair, or drinking lots of water prior to the appointment, so that the numbers on the scales may not reflect what's truly going on. And this then protects the eating disorder. You're asking that young person who's taken the courage to come and talk to you to do the very thing that they fear the most. Talk about this and how you can manage this together. It may be that you agree that the patient doesn't need to know their weight, but only you can see it, or you could reassure them that their weight is only a part of your assessment and you're trying to get an idea of the whole picture and who might be the best to support them right now. BP and pulse, sitting and standing, temperature, baseline bloods if indicated. Don't delay the referral to wait for the blood test results. Time is so important when referring young people for eating disorders assessments. So often people have been told they're not thin enough for referral, and the ED has seen this as a challenge, so they've gone away, lost further weight until they've ended up as an emergency. Emergency treatment should be sought if someone presents having not eaten or drank fluids for 24 hours, if they're cardiovascularly compromised or fainting, or if their median BMI is less than 70%, if their pulse is less than 40 beats per minute sitting, and if their temperature is below 35 degrees. That's from the Junior Marzipan Guidelines. So, common questions asked. Does my patient have an eating disorder, and if so, what can I do? NICE guidelines suggest considering a range of factors when deciding whether to refer someone for treatment. Because of the highly specialised level of care required for people with eating disorders, NICE recommends immediate referral for specialist assessment. Ensure you enter eating disorders into the SNOMED CT read code. Another question is, would it be better to wait to see if things get better or worse before referring? No. Patients should be seen and assessed and receive treatment at the earliest opportunity, and there can be serious long-term consequences to delaying referral. Their weight isn't dangerously low. Should referral be delayed? No. Eating disorders are mental illnesses, and it's not possible to gauge whether someone has only using physical parameters such as weight, which may go up and down or stay the same. No single measure should be used to determine whether to offer treatment. The patient is denying there's a problem. Maybe this is a phase. People with eating disorders often struggle to acknowledge or even recognise they're ill, and the concern of those around them should be considered too. Who's the best position to make an assessment? NICE recommend that anyone with a suspected eating disorder should be referred immediately to a community-based, age-appropriate eating disorder service for further assessment or treatment. What to include in your referral? Their name, their age, who they live with, their school or occupation, the eating disorder presentation in brief, their weight for height or BMI, the history of weight loss, what the current risk, physical and psychological risk factors are, any family or carer concerns, what information and signposting you've done so far, and what ongoing medical monitoring plan you've put in place. Below are a resource list for families and patients that you can print out. These will be available on a printable A4 sheet for you to be able to empower the families to begin to understand about eating disorders and empower them to make the changes that need to be addressed. These are all further resources and further links that you can give to families and patients who present.
Treatment paths are identified and many of the interventions and responsibilities lie within primary care. One challenging aspect will be for health commissioners to ensure that services are adequate to back up the primary care team. In many areas, the child and adolescent mental health services have difficulty meeting demand, inpatient facilities are scarce, and psychological therapy services under immense pressure. This should not deter you from referring. Listed here are the local referral pathways. We have the Young People's Eating Disorder Service for referrers from North East Hampshire area, the Children and Young People's Eating Disorder Service for referrers from Surrey, Heath and Farnham areas. There is also the contact details for the Adult Eating Disorder Services in Berkshire and the Eating Disorder Services for adults in the West Surrey area. And Hampshire Specialist Eating Disorder Services for adults. So the key learning outcomes that we have covered within this webinar are early identification, the early warning signs, risk factors, clinical features, impact and prevalence of eating disorders, increased understanding of the common challenges experienced by clinicians identifying people with eating disorders, understanding from sufferers of eating disorders about how they confronted their illness and GP support, understand how to access service for an eating disorder and manage risk, including engaging families and support, and recognising the official guidance and care pathways available. What I would like you to take the time and opportunity to do right this moment is to think about what I commit to do. So think about what you commit to do differently as a result of this webinar. The online resources for GPs outline a list of resources that you can access that will help you in making your referral and understanding further about eating disorders, alongside the risk management references.